So these are just the objectives of what I hope you guys can take away. I'm going to go through the diagnostic criteria for Parkinson's disease, mild cognitive impairment, and Parkinson's disease dementia. I'm going to talk a little bit about approaches to assessing instrumental activities of daily living in Parkinson's, which turns out to be a really important endeavor that we've been involved with. And then the third thing I want to talk about is how Parkinson's disease dementia differs from other dementias, and really kind of define those terms a little bit more, because I think that's one of the scariest things that people think about when they hear the word dementia. A lot of people equate dementia with Alzheimer's disease, and a lot of people think, oh, I have Parkinson's disease and Alzheimer's disease, and it's really a different condition, and I'll try to explain to you a little bit about how those things differ. And then I'm going to talk to you about some of the non-pharmacological approaches to treating cognitive deficits in Parkinson's. And this is actually just one slide, but I probably could do like 15 slides on it now, which again is that hope. But I just kind of want to have the take-home messages in terms of those interventions. So as people know, people who are dealing with Parkinson's on a day-to-day basis realize it's not just a movement disorder. They use the term non-motor symptoms to describe those non-motor symptoms, and I think it really does a disservice to some of the other symptoms that actually impact quality of life to a much greater degree than the motor symptoms. Even in some of our research, we find that it's not the motor symptoms or the severity of the motor symptoms that dictate the quality of life that a person might report. It's these other symptoms. It's the cognitive issues. It's the mood issues, the anxiety, the apathy that can also go along with that. So the field is kind of moved, not away from trying to understand the motor symptoms and deal with the motor symptoms, but it's moving away from those being the cardinal symptoms, is the terminology that used to be used of Parkinson's. In fact, there's now a movement to try to start developing ways of detecting and predicting someone developing Parkinson's disease based upon these non-motor symptoms. So things like REM sleep behavior disorder, loss of taste or smell, constipation, all of those things are now going to be looked at prior to the development of the motor symptoms. Obviously, the earlier we can detect whether someone is at risk for Parkinson's, the better off we're going to be when those treatments are available. Or at least should treatments be initiated earlier than when the motor symptoms start. So there's really a movement towards these non-motor symptoms becoming some of the cardinal symptoms that people have to deal with, not just in terms of predicting who's going to develop the motor symptoms down the road, but also in terms of focusing on those as endpoints in and of themselves in terms of treatment. So if someone is having issues in terms of cognition, that's something we need to deal with, and that may be more important than dealing with some of the motor symptoms, because as some of you know, with Parkinson's, it's always a trade-off, it seems like. There, you fix one thing, something else gets worse. You fix that thing, something else gets worse. And these medications just kind of are affecting these different systems in different ways. And as you might anticipate, you balance that seesaw for a little bit, and now you got to go back to trying to balance it. So it's really something that has to be looked at as well in terms of what are the symptoms that are going to be focused on. I'm going to give you lots of tidbits of suggestions that I make to our patients. So one of them that I always like to suggest is that to have a list of your symptoms, okay, and identify what are the symptoms that are most disabling to you, and keep that list. And when you go to your doctor, you can pull that list out. Any of your doctors, you can pull that list out and say, this is the one that bothers me the most. I want this one to be treated in as best a fashion as it can be, and I don't really care about these other ones that much. And that list is going to vary from person to person in terms of what they're more concerned with. I remember having a conversation with a patient who was going to undergo deep brain stimulation surgery, and I was telling him the side effects, potential side effects associated with DBS surgery in terms of the cognitive changes. And he was like, whoa. He's like, I'm a trial attorney. I don't want to have my cognition change. I don't want to have my memory go, any doubt, lose memory in any way, shape, or form. I don't want to be slower in my speech production. He says, I may just want to stay in a wheelchair for 3 years while I litigate and make enough to retire, and then I'll have the surgery. So again, someone else may come in and say, I don't care if I can remember your stupid word list, Vince. Give me the surgery. I want this symptom to be fixed. So it really depends on from person to person. So that's why I think it's really important to keep that sort of list so that you can go to your primary care doctor and say, this is my biggest concern. You can go to your neurologist and say, this is my biggest concern. And it really helps you guys work together because each doctor you go see is going to have their own agenda in terms of what they want to fix. And whether they ask you if that's a good thing or not, good luck. Doesn't always happen. Okay, so this is a little bit difficult to see, but I will be giving out a PDF to Nancy and Ron, and hopefully they'll be able to distribute that. But this just kind of goes through, this was a study that was done in 2015 that just looked at a fairly large sample of patients, 268, and determined which symptoms people are reporting the most of. Prior to 2010, each symptom was viewed in isolation and not looked across the board in terms of what are the most important things here in terms of the prevalence. And what we see is that a lot of the symptoms that are pretty high on the list in terms of the percentage of patients that are experiencing them are these non-motor symptoms, including the cognitive impairment, where it's about 74%. Now, this is all based on self-report, the person feeling that their cognition has changed and it was related to Parkinson's. Depressed mood is about 60%, anxious mood is about 56%, and apathy is about 45%. So if you look at that in terms of some of these other symptoms, which are the non-motor symptoms, nighttime sleep problems, 71%, urinary problems, 71%, fatigue, which is actually an area that we're actively studying, 68%. They rank pretty high up there in terms of what non-motor symptoms people are experiencing. And then if you look at this in terms of health-related quality of life, this PDQ-39 is a common scale that we use that's very specific to Parkinson's. It asks, how is your Parkinson's affecting you in terms of your mood? How is your Parkinson's affecting you in terms of your mobility? And it breaks it down into a total score as well as these subscales. And it looks at the correlation. So this is just a correlation. The higher the number, the more it's associated with the health-related quality of life. And you can see motor symptoms are actually lower than these non-motor symptoms. So again, making that argument that yes, the motor symptoms are very much important in terms of quality of life, but these non-motor symptoms, which include these things down here, cardiovascular issues, sleep issues, mood and apathy, all of these things are contributing a lot to how one's quality of life is when they're dealing with Parkinson's. And when you look at cognition and mood just by itself, it's a pretty big correlation, and if not as big as the motor symptoms themselves. So cognition in Parkinson's disease. Let's talk a little bit about that. So why is it important to understand that? Well, there's now thought to be this sort of cascade where one goes from normal cognition, meaning that they're performing where they should be relative to their age. Now, when I talk about mild cognitive impairment and I talk about dementia, keep in mind we take into account someone's age when we do our evaluations, because a lot of times people will come in and they'll say, my memory's slipping, but I really don't know if that's due to the fact that I'm 75 right now and I'm got a lot of stuff going on, or if it's due to Parkinson's. So that's an important question that we have to tease apart. So when I talk about PDMCI or PDD, it's above and beyond the effects of just the aging process, what I like to call the unfortunate normal cognitive aging process, because it's all downhill after 14. So I don't see anyone in here who's not on that slippery slope. So that's what I'm talking about in terms of just kind of this cascade. And really where a lot of research has been focused is, one, initially trying to just characterize these things. We couldn't characterize these things very well because a lot of the tools that we had in terms of the behavioral and neuropsychological evaluations were based on Alzheimer's disease. And I think that kind of set us back in a way because with Alzheimer's, memory is king, in the sense that memory impairment is the thing that you test for primarily when you're looking for what used to be the dementia umbrella, which was primarily Alzheimer's. In Parkinson's, that's not the primary presentation. It's not the rapid forgetting. It's not the repetition of questions or anything like that. That can be some component of it, but it's not the main feature that you see, particularly early on in the course of the disease. So we didn't have the tools back then to really say, okay, are we really picking up on mild cognitive impairment? Are we really defining dementia the way that we should be? But we ended up getting Alzheimer's disease back. The drugs that they developed for the use of Alzheimer's disease actually work better in patients with Lewy body disease, such as Parkinson's and dementia with Lewy bodies. And we might talk a little bit about that depending on if I go down that pathway. So this is a slide that I like to put up, where we talk about better cognition on the vertical axis and time. And typically, we have normal cognition. Again, that's just that nasty normal aging process that we all are faced with. In PDMCI, this might accelerate a little bit more. And at this point, this person may be, at that time, having lower cognition. And then as far as the Parkinson's disease dementia, we see it happening further down the road. So one of the biggest predictors of the development of dementia in Parkinson's is how long has someone had the disease, something we have no control over. But what I'm hoping to explain to you here is that when we start talking a little bit about some of the potential interventions, really what we're trying to do with the interventions is not necessarily eliminate Parkinson's disease dementia. Now that would be awesome if we could do that. I mean, that is the goal, obviously, or eliminate people from transitioning from normal cognition into Parkinson's disease, mild cognitive impairment. What we're really trying to do is to, and I like to use the term, flatten this line out. We're really trying to get it from going this steep to perhaps going to there. This much difference would make a world of difference in an individual person's life. And that's really what we're trying to do with a lot of the interventions that we're developing and working on now. And I'll get to that. So this was a study that was done all the ways back in 1999. And only did people start citing this within the last 10 years, 15 years, and seeing its importance. But what it's showing here is that as a cumulative proportion of people who do not meet criteria of dementia over basically a 10-year period. And what it's showing here is blues, Parkinson's, and red are the controls. And they start off at the same place. What you see with the controls over 10 years, not much change in terms of the people who meet criteria for Parkinson's disease dementia. But as far as Parkinson's disease, you start to see some drop-off over time. And by the 120th month, the 10th year, you're seeing that roughly 50% of patients are meeting criteria for Parkinson's disease dementia. So, what is Parkinson's disease mild cognitive impairment? It's thought to be a transition state from normal cognition to dementia. And it's defined by deficits in at least one area of cognitive functioning. I'm going to get to the more fine-grained definition of it. And it represents a decline from previous level of functioning. So we all bring our own cognitive baggage into our offices and labs to get these neuropsych tests. Some people are functioning very high to begin with, other people not so great, other people right in the middle. That's just kind of how the normal curve works, so to speak. So in order to meet criteria, it has to represent that there's been a decline from this previous level of function. We define that in a few ways. One is through our objective neuropsychological evaluations, where a patient comes in, spends about 3 to 4 hours with us, getting paper and pencil types of tests, being told silly little stories and asking to remember those stories and say back as much of the stories as they can, and then doing that 25, 30 minutes later. And then comparing those test results to hundreds, if not thousands, of individuals in that person's age group who have no history of neurologic or psychiatric conditions, to see, relative to their age-matched sample, are they performing below expectations. The other way to do it is to compare apples to apples, which is to have somebody get their baseline testing and then come back in a year or two later and see if things have changed since that time period. So that's why the serial testings are important. The other thing that's important about mild cognitive impairment is that it does not result in significant problems in performing activities of daily living. Now, there's a hitch with that in Parkinson's. How do you disentangle the motor symptom contributions to the cognitive, or away from the cognitive contributions to doing things such as writing a check? If the person's micrographic and you're having difficulty reading your handwriting, does that mean that they're having problems in terms of performing their activities of daily living? Well, yes, it does, but that's not likely related to the cognitive functioning or difficulties that one might be having. So that's one of the challenges that we have in terms of saying somebody has difficulty in performing their day-to-day activities. We'll oftentimes ask family members, well, we know that there's a lot of tremor and the person is having difficulty writing checks and so on and so forth. But would you feel comfortable going to them and asking them, well, we have to, we don't have a lot of money this month, and, we have two big, would you be okay if we were just to write a small amount for the check towards the credit card and just pay the minimum balance this month or something like that? So little questions like that kind of help us tease that apart. We also have more objective measures that I'll describe a little bit in terms of evaluating things such as money management and medication management, which tend to be the two big things that we look at, as well as driving is another issue. And I could give you a whole 2-hour lecture on driving. So how frequent is mild cognitive impairment in Parkinson's disease? So Dr. Irene Litvan, who is the director of our Movement Disorder Center at UCSD, and the Movement Disorder Society study group, got together and reviewed all these papers on Parkinson's mild cognitive impairment. And they came up with this number of about, at any point in time, 26% patients will meet criteria. And at the time, the criteria were very loosely defined. It was acknowledged that that was the case, but it was very loosely defined. The frequency increases with age, disease duration, and disease severity. And there are a number of other things that are associated with cognitive change in Parkinson's. Having falls early on in the course of the disease, although some people might even argue that that's not Parkinson's that they're dealing with. So again, a lot of these definitions that I'm going to be describing are somewhat fluid. I think this was an interesting study that was done, I think around 2010, that even in patients who were newly diagnosed and never received any medication treatment, about a quarter of them had mild deficits in 2 or more cognitive domains. So this study was done, I forget which, I think it was in England. The person walked through the door, and it was at all service clinic. They got the diagnosis of Parkinson's, and they went up the hallway and started doing neuropsych testing with a neuropsychologist. So these are people that are just dealing with a diagnosis, as well as just not having been exposed to any medications, which can also cause problems in terms of thinking. And yet a quarter of these people were meeting criteria for mild cognitive impairment. So it is something that is occurring much earlier on than we had suspected. So why diagnose Parkinson's MCI? Some people will just say, well, it's just if it's inevitable and it's going to happen, why should we even worry about this? Obviously, the most optimal time to implement any intervention that can improve current and future cognitive decline, the earlier the better. Any disease state is like that, practically. The earlier you can detect it, the better off you're going to be with the treatment. When I was in that gray period where we didn't have a lot in terms of advice or studies looking at how to intervene and slow down or improve cognitive impairment, I was always a little bit shaky on that one. But now I'm a big believer in that, in the sense that the better you can train your body up to be able to withstand what Parkinson's can do, the better off you're going to be down the road. And that's certainly in regards to cognitive functioning as well. So there are some implications for performing some aspects of instrumental activities of daily living. I'll go into more details about that. And I think this third one is really important. And this is more kind of getting back to the power of knowledge. and how it's important to have an understanding about what's going on with you. So what we've found and what others have found is that these cognitive difficulties are often underreported by patients and their families, but they can have a greater impact on quality of life than motor symptoms. And I hope I made that argument cogently in the first couple of slides that I presented. So just knowing how you're doing in these areas that I'm going to talk a little bit more about provides you with some power in terms of understanding what is it that's going on with me right now. Do I need to worry about these things? Do I need to double check balancing the checkbook? Do I need to be more careful when I drive? All of these sorts of things are helpful in terms of putting one's mind at ease and just knowing ahead of time, I need to be able to concentrate more when I get into this situation. Or Dr. Filateo says, this is the circumstance under which my memory operates best. Those types of things can be very, very helpful for people. So this was the article that came out of the original paper, which was authored by Dr. Litvan. And this is the one that the Movement Disorder Society Task Force decided to come up with the criteria for diagnosing Parkinson's mild cognitive impairment. This was only 5 years ago, guys. So we are barely on the tip of the iceberg of trying to understand this. I'm now involved in the task force that's trying to validate these criteria that have been published. And we're having an interesting going back and forth between folks in the Netherlands, in Italy, up in Canada. I mean, there are a number of patients, over thousands of patients that are participating in these studies. But the development of the criteria was the first step because, again, you have to be able to define it before you can study it. And these are the formal criteria that were put forth by Dr. Litvan and the study group. That the formal criteria was authored by the Movement Disorder Society. Their diagnosis is based on either cognitive screening tools or detailed neuropsychological testing with a preference for the latter. And then with detailed neuropsychological testing, 5 domains have to be evaluated. And let me see, these are the domains that are evaluated. Executive functioning, which include things like problem solving, abstract reasoning, cognitive set shifting, multitasking, and inhibition. And in fact, it's executive functioning that is thought to be the area that's impacted earliest in Parkinson's. So this may resonate with some people who found that they're having difficulty in terms of multitasking. Attention and working memory, which is focus or divided attention. You can think about divided attention when one is driving, that you're having to attend to the car in the left lane, the car in the right lane, that sort of thing. Maintaining information in short-term memory. I tell you my telephone number. Are you able to remember that and tell it back to me? Those types of things. Language, which include production, comprehension, and word finding. That area tends not to be impacted to a large extent in Parkinson's. It's included because it helps us rule out other conditions that might be impacting cognition, such as Alzheimer's disease, where language can be affected early on. And then memory, encode, consolidate, and retrieve. Those are the 3 stages of memory that we focus on in our assessment, and I'll talk to you a little bit more about that. And then visual cognition, spatial judgment, object recognition, visual construction. Visual cognition is actually an interesting domain in relation to Parkinson's. We're now actually seeing in some of our preliminary data, as well as other studies that have been published, that visual cognition and deficits in that domain are unique predictors of the development of dementia down the road. And it's unique in the sense that poor scores on measures of executive function have always been known to help predict Parkinson's dementia down the road, but visual cognitive deficits are unique predictors on top of that. And the more we understand how these different domains are predictive, the better off we're going to be able to tell somebody, look, you're coming in and you're showing this profile. We're not thinking that you're going to have any major issues within the next 5-10 years type of thing. Or you're showing deficits in both of those domains. It's like, okay, we need to work with you in terms of some of the strategies I'm going to talk to you a little bit about. So how best to diagnose it? So right now, these are the main criteria that are being used. So someone has to have an impairment in two tests within a single domain of those 5 that I showed you, or 1 test in 2 different domains. We're actually finding in the study group that this is a little bit more liberal, and where the percentage of patients that we're identifying and diagnosing with MCI is much higher than what we typically use. So we're already starting to contemplate making adjustments to this just based upon, the last 2 years of study that we've been doing. Again, it has to represent a decline in previous level of functioning. The impairment is not significantly impacting activities of daily living, and this is often evaluated via patient or family member report, but now again we're moving more towards objective evaluation of that. And that you should specify the subtype of Parkinson's MCI. So rather than what they typically would do in the Alzheimer's arena of mild cognitive impairment, where they would just simply say amnestic MCI or non-amnestic MCI, when we turn in our data for this study group, they want to know which of the domains are impacted. And that's going to be very, very helpful in looking at it down the road. And in fact, we are seeing that executive function tends to be the area that's most impacted. But some of these other areas, even language to some extent, can be impacted as well, too. So I think we're going to learn more about it by making that specification. So one of the things that, and this is always a rift between neuropsychologists and neurologists, the classic rift. Neurologists always ask, why do I need to send a patient in to see a neuropsychologist when I can just do a mini mental status exam in 5 minutes, or a Montreal cognitive assessment, in 8 minutes? Why do I really need to send them to you? And I was up against that a lot in terms of a lot of the neurologists that I've worked with through the years. But what we're finding is that a couple things, is that in using probably one of the more sensitive screening measures, which is the Mattis Dementia Rating Scale, that we're not seeing too much in terms of leeway between a perfect score on that scale, which is 144, and using that to make the diagnosis of PDMCI, where if you lose 4 points, that's where you would meet cutoff for screening, and then for diagnosis, a 137, which is only 7 points. We see 133s, we see 134s all the time in our patients using this particular screening device, and they don't meet criteria, the more formal criteria for the PDMCI. So there's somewhat of a low correlation between using the screening measures and using a more detailed neuropsychological evaluation. In fact, it's always now a joke in our treatment team meetings where the neurologist who saw the person says, well, I don't even know I'm going to report the MOCA because Dr. Filateo is going to say something completely different than what I'm saying right now. So it's something to consider in terms of how detailed of the evaluation that one should get. And I think most neurologists are coming on board that a more detailed neuropsychological evaluation is going to be more helpful. Okay, I mentioned that there's a low correspondence between the level 2 and the level 1 and the level 2 diagnoses, which is the screening versus the more detailed evaluation. This most likely has to do with the psychometric abilities of the screening measures. And the gold standard really is detailed neuropsychological evaluations. We and other groups have even taken it to a higher standard in terms of our research. So when we go and do the Parkinson's disease mild cognitive impairment diagnosis, we do a consensus diagnosis where there are 3 of us who independently look at the chart and look at the history and look at some of the questionnaires that we give, make our diagnosis, and then come together. And so the 2 people that did the evaluation, if everything is accurate and consistent, the 3rd person doesn't have to come in and play. But if there's a discrepancy, then the 3rd person is the one who makes the call in terms of breaking the tie. So we're being even more stringent about it than we had in the past. So let's talk a little bit about Parkinson's disease dementia. And I think Nancy kind of hit the nail on the head, as she oftentimes does. is that a lot of people look at this as being, and yes, it is a serious thing, and it is something that we do have to think about, but it's not a death sentence, by no means. What I tell people to take the edge off of that diagnosis is just simply it's a behavioral description of having problems in 2 areas of cognitive functioning, and that it's significantly impacting your day-to-day life. And when you say it that way, I couldn't probably meet that criteria in some ways or another. It doesn't sound as bad, but it is certainly something that needs to be attended to and considered. But by no means does it mean that you're going to be this blathering person in the backwards in 2 weeks or a month or 2 years or whatever. The other thing that has struck me about this curve here is that even though this might represent an arbitrary mean, you plot individual people in terms of their cognitive performance across time, and there's so much variability. There is so much variability that when someone comes in and they say, okay, look, this is what my baseline neuropsych profile looks like. Tell me what I'm going to look like in 2 years, doctor. And I'm like, I can't. That's the focus of our study, is trying to be able to predict that. We just don't know. The mean change or the variability of the change is oftentimes 3 to 4 times the amount of actual change that occurs. And that really just tells us that there is so much from one person to the next that we can't tell anybody. That's this question back?
Can you tell on a patient when they're going to the PDI, MCI at that stage into the dementia? Is there some way that you can tell?
Yeah, so I'll get to how those are differentiated, and a lot of it, just to kind of cut to the chase, has to do with, are these problems impacting them in their day-to-day life? That's probably the main one that one would focus on. Okay, so what is Parkinson's disease dementia? It is not Alzheimer's disease, okay? But with that said, that doesn't necessarily preclude one from developing Alzheimer's disease. And there's thought to be some overlap in terms of them. But it's clearly not the presentation that we see in Alzheimer's disease as far as the cognitive performances are concerned. So again, the definition, deficits in at least 2 areas of cognitive functioning based upon those same domains that I described. The impairment obviously has to be worse than what one might see in mild cognitive impairment. Again, it represents a decline from previous level of functioning. And the main thing, again, is that it results in these significant problems in performing these complex activities of daily living. And it's beyond what is due to the other symptoms associated with Parkinson's disease. So again, are there problems in terms of writing checks, managing medications, taking care of their appointments, all those sorts of things? And are those problems related to cognitive functioning and not the motor functioning, not the hypophonia, the loss of being able to project one's voice, any of those things? It has to be related to the cognitive functioning. So how frequent is it? So the point prevalence has been shown to range from 22 to 48. It accounts for about 3 to 4% of dementias in the general population. And the incidence studies indicate that approximately 10% of patients of a PD population will develop Parkinson's disease dementia per year. Now, one of the issues with that is that those studies that looked at the development of each year in terms of the incidence didn't take into account the diagnosis of MCI. So those people were mixed with MCI patients, or that study mixed MCI patients with cognitively normal patients. So the prevalence in people who have no cognitive problems is probably going to be much less than that. Or I'm sorry, the incidence. How many convert to a dementia? Simply because there was a mixture of those groups in those studies. So the cumulative epidemiological prevalence studies are now showing, like I mentioned earlier, that patients will more likely than not develop Parkinson's disease dementia with time. Okay? With that said, most of us who live to a certain age will develop a dementia down the road. The question is, in Parkinson's, how specific is it to the disease? And again, kind of getting back, is there anything that we can do about that? So this is just the paper that was developed, or that was published in only 2007. I mean, this was just 10 years ago. where they talked about dementia and the clinical diagnostic criteria for that. So these are still the criteria that are used that were published by this other movement, Disorder Society Study Group. So how do you diagnose Parkinson's disease dementia? And these are basically reiterating the things that I just discussed. And these are the formal diagnoses from the paper that I just showed you. And again, the key features are in terms of the problems are impacting daily functioning above and beyond what is due to the other symptoms, as well as causing significant problems. And I think that's an important point to make, particularly given some of the studies that we looked at. So we've been trying to study lab-based measures of medication management and financial management. So it's things like, okay, here's a blank check, here's a pen, here's an SDG&E bill. Show me how you would pay that check, show me how you would balance your checkbook. And each of those things are scored along the lines. We don't take off points for micrographia or slowness in responding. They're given as long as they're needed to. We do time them, of course, to see if they are taking more time. And then in terms of medication management, we say, okay, here's a regimen of medications. These are the pill boxes. These are the actual pill containers. We want you to show us that you can lay out your pills in this hypothetical regimen for the week. And we just see, can patients do that? And are there anything problem? I mean, it's like one of those things, it's like, duh, if you want to know if they can do it, ask them to do it. And so we started taking that on, and we found that there are some interesting things. So in terms of medication management, so this was a study where we looked at MCI patients using the more strict diagnostic criteria relative to patients who had no cognitive problems, the PD-NC group, relative to HC, which is healthy controls. Medication management and finance management were not very well correlated with one another. Again, suggesting these are different things that we're evaluating here, as one might think. But when someone does have the diagnosis of MCI, they come in, they see us, we make the diagnosis, we start being a little bit more concerned about medication management than we might be about financial management, and just simply saying this is something that you and your family need to keep an eye on in terms of that issue, particularly because of some of the concerns with medication management that can impact Parkinson's patients to a larger extent. One of those is that inconsistent use of medications, over-medicating or under-medicating, can possibly lead to the development of dyskinesias, simply because there's not a steady stream of dopamine in the system, causing these receptors that cause the dyskinesias to start to grow and sprout. So it does have important implications. And certainly, if we can catch it that early on and say, okay, this is an issue that this person might have, let's pay special attention to that, it's going to make them less likely to develop the dyskinesias down the road. So important implications. So this, I just want to kind of highlight the difference between Parkinson's disease and Alzheimer's disease in terms of these cognitive domains that I've been discussing. So as I mentioned with Parkinson's disease dementia, it's those executive functions that tend to be impacted early on and most hard. In Alzheimer's disease, it's memory as well as some language. So naming seems to become a problem where people are having difficulty in terms of coming up with the names of common objects, something that we all do, but it's much greater in terms of Alzheimer's disease. Let me talk to you a little bit about memory, because that tends to be one of the things that people are most concerned about, is what memory is and how it's evaluated and so forth. So I liken the encoding stage of memory in terms of being able to take a file, using the filing cabinet metaphor that I like to use, labeling that file in the appropriate place or in the appropriate way, and then putting that file into the right place in the filing cabinet. The consolidation stage is just simply making sure that filing drawer is shut and everything is good. And then the retrieval stage is going and getting that information out from that location. Obviously, the retrieval stage is impacted by the encoding stage. It's much easier to find a file if you label it appropriately, put it in the right drawer, and you're organized, than it would be if not. And then the consolidation stage is the one that's most impacted in Alzheimer's disease. So basically what occurs in Alzheimer's is that, yes, there's low encoding. Not much is encoded or not much makes it into the file, but almost nothing makes it into the filing cabinet, and certainly that door doesn't shut the right way. So what little is learned is lost in Alzheimer's disease. In contrast, in Parkinson's disease dementia, the area that are most affected are in the encoding and the retrieval stages. And this actually allows us to make specific recommendations about how to improve one's memory in Parkinson's, to develop compensatory strategies. So one of the examples that I will always give is that patients with Parkinson's almost always do better when they're asked to remember stories than when they're asked to remember word lists. And the reason being is that the stories provide a semantic relationship amongst the information that's being asked to be remembered. By definition, stories are semantic. In word lists, that's not the case always. So when that's the case, the encoding is much easier for stories than it is for the word list, and therefore much better, higher fidelity information is going to make it into that filing cabinet and going to be easier to retrieve. Now, the other stage that tends to be impacted in Parkinson's is the retrieval stage. And what that tells us is that people are having difficulty kind of organizing how to go about and open up that filing cabinet. Which drawer did I put that in, type of thing. And one can alleviate those problems by developing cue strategies. Family members can develop cue strategies. The simple example that I give is, rather than asking somebody, what did you have for breakfast this morning? Did you have bacon and eggs? Yes or no? Did you have pancakes? Yes or no? I always use myself as an example because I'll misplace my keys, and I'll go back and ask myself, okay, did I leave them on the coffee table? Yes or no? Did I leave them on the kitchen table? Yes or no? Did I leave them in the front door? Yes or no, which happens sometimes. So being able to help that information get accessed is one way, another way that can help in terms of improving the memory in Parkinson's. The other thing that occurs, too, is that, yes, sometimes encoding may not be good, but what makes it into that filing cabinet makes it in and is consolidated. So there's not this rapid forgetting that you'll see in Alzheimer's disease. So again, it's more at the encoding stage. Okay. So let me get to flattening that line and talk to you a little bit about some of the things that are in the hopper and beyond, actually, in terms of improving. Like I mentioned earlier, I came in and would say, okay, these are the point prevalence, these are the numbers, this is all bleak and blah, blah, blah. Now we have some ways of combating this, and I just want to talk to you a little bit about that. So basically what we're trying to do in this scenario, like I mentioned, is just to kind of flatten this curve out. And this amount of change in terms of flattening that curve out is going to have a huge impact in terms of people's lives and family members' lives. So the more that we can do, the better off we're going to be. Okay? So these are some of the promising non-pharmacological interventions, and we're involved in some of these at UCSD and the VA. So cognitive rehabilitation has been traditionally thought of in two different ways. One is restorative and the other is compensatory. So restorative mechanisms, the example I like to give is that if I were to hurt my right arm, my physical therapist might get me to work that arm. That's what likely they're going to do. They're going to try to get me to restore the function of that arm. Whereas compensatory is that another physical therapist might teach me how to do the same thing with my left hand. And so that's kind of been the approaches in terms of cognition. Restorative, video games, like the Lumosity, doing things that, people like these games that are working your working memory. You're working that muscle, for want of a better term, in your brain that is involved in executive functioning. Cognitive practice, it's like, okay, I know I'm going to go into a room and meet lots of people. How am I going to remember that person's name? There are different approaches that can be used to doing that. The example that I give is that, you walk in, you meet some guy, he reminds you of your cousin Sam, and just doing that amount is going to help you remember that a little bit more down the road. That also falls into the compensatory, where we have these kind of mnemonic strategies, the use of smartphones, pill boxes, these things that are going on the left arm instead of my right arm in terms of making use of those things. So currently, we have a trial going on at the VA and UCSD that's focused on the compensatory strategies. And I actually have some flyers up here that if people are interested, they can take a look. And I'll give you guys my number and my lab number as well, too, so you can give us a call if you're interested. But the compensatory strategies are being taught in a 10-week program where we have patients, well, we first have them come in, they do this neuropsychological testing. We're actually doing structural imaging with them as well. Then we're running them through this 10-week psychoeducational kind of compensatory class where they're taught very much like I'm teaching you guys right now about some of these difficulties that people can have, but also teaching them how to compensate for them in much more detail. There's homework involved, so keep that in mind. You have to go home and practice these things, or else you're not going to do it. Who's gone through the big program or the loud program? And one of the big one of the big things they emphasize is you need to practice these things. It's really you use it or lose it type of thing. And that's what we focus on with the compensatory strategies and this program that we have called CogSmart. That's at the that's part of the study that we're involved in. Physical activity, wow, we're seeing a lot of really impressive data coming out of this, the studies that are looking at this. So there's aerobic, there's skill-based, there's balance. I like to break these up into these 3 different types of exercise because people are like, well, what do you mean by exercise? We didn't know in the past. It's like get out and walk, do something, you know, don't sit in front of the TV is how it was defined. But now we're learning more about these things, that aerobic, skill-based, and balance types of exercise. Each has their own ways of improving things in Parkinson's, whether it be improving the balance through Tai Chi and yoga, improving the motor system learning through skill-based, which is boxing or tango types of things, or just increasing the blood flow through the brain, which I describe as when that blood is rushing through your brain and you're taking out all the garbage, so to speak. All 3 of these are now showing benefits in terms of not just Parkinson's, of course, but just the normal aging process. So when I have patients and their family members in my office talking with me, I tell the other people too, look, you need to get out and do these things too. I need to get out and do these things too. It's not just specific to Parkinson's, but it really is helping. Let me talk to you a little bit about some of the research in skill-based exercise, because I think this is pretty impressive. So there's a group at USC that we're collaborating with, Giselle Petzinger and some of her colleagues up there, that we're looking at a rat model of Parkinson's disease, or a mouse model of Parkinson's disease. And what they did was they wanted to compare a skill-based group of mice, or rodents, to a non-skill-based group, to just a basic aerobic. Well, how do you do that? They came up with a very clever way of doing that. So those little wheels that they're on, in the aerobic group, that's all they did was to work that little wheel. And if they slowed down, they got just a little shock, I think. Versus the skill-based group, where they randomly removed rungs on that wheel. And now what the rodent had to do was pay attention. Where is my hand? Where is my paw relative to where that rung is missing? So they were having to integrate the motor movement with the cognition. And we're thinking that that's a huge component of why this skill-based type of exercise works. If you think about what you're doing when you're boxing, you're working on the eye-hand coordination. And that's a really, really important component. You're hitting both the thinking and the motor and the integration of those 2 things. So I'm really excited about the future of studying that, and I really recommend that. And then, again, with the balance issues, a lot of times people will complain. People with Parkinson's will say, well, I'm having difficulty with that. I can't really do that. I can't do the yoga. I can't do the Tai Chi. There are different adaptations that one can use where you can do chair yoga, chair Tai Chi. You can do these things in the pool. So there really are no excuses for any of these things. The other thing is emotional. And I'll talk to you just a little bit about some of the importance of emotion. We know, for example, that anxiety exacerbates the motor symptoms of Parkinson's. In fact, we see a correlation in our sample of patients between anxiety and freezing. In fact, anxiety is thought to be one of those prodromal symptoms that patients might have, where more often than not, I'm asking patients, well, what are some of the first symptoms that you've seen? And they focus on the motor symptoms and all that. And it's like, well, what about anxiety? And it's like, oh, yeah, that's been going on for a while. Well, what about loss of taste? Oh, that's even further. But I mean, the mood issues are definitely there early on. In fact, they are considering that as being one of the prodromal symptoms that one might have. So there are treatments for these mood issues. And I'm going to go into a little bit more about mood in Parkinson's, if that's okay. We're hitting 8:30. Is everyone doing okay and willing to put up with me for maybe 10 or 15 more minutes? Okay. So I want to talk to you a little bit about mood in Parkinson's disease and the importance of also understanding that as well. So this is a cohort of our patients. We're now up to about 170 patients that we've seen at baseline, and I'm hoping that we're going to get up to 250 within the next year or so. But this is the percentage of patients that, just looking at these things in isolation, that have depression, anxiety, and apathy of that 121 sample. Apathy is much more prominent in our group than we're seeing in other groups. The other thing that's interesting, this just shows the percentage of the co-occurring symptoms. About half of our patients, 46%, have no significant mood symptoms in depression, anxiety, and apathy. And this just shows you kind of the combination. Well, do they have depression in isolation? Do they have anxiety in isolation? Do they have apathy in isolation? One of the more interesting things here is that depression doesn't occur by itself. And I think that's an important take-home message, because oftentimes physicians will just focus on the depression and not consider these other symptoms in terms of treatment or monitoring. Apathy seems to appear by itself much more commonly, in our sample at least, than the other conditions. And you can see that roughly 10% have a combination of the depression, anxiety, and apathy. And what we're looking at now is having one more detrimental or more associated with more severe motor symptoms, the cognitive symptoms, the early constipation, all those types of things. We're trying to kind of tease that all apart. The thing that I think is very important is just looking at how these things relate to different variables. So kind of this is the quality of life that I had talked to you about, where how does Parkinson's impact me physically? How does Parkinson's impact me in terms of emotional well-being? All those sorts of things. And these just show the correlations between levels of depression, anxiety, and apathy, and how they relate to quality of life. Depression actually is the better predictor of quality of life. So even though it's in a low percentage of patients, let's not throw that baby out with the bathwater. That's something that we still have to attend to, because if it is present, it's going to definitely impact one's perception of their quality of life. In terms of caregiver burden, these are significant correlations, and there doesn't seem to be much difference in terms of whether the depression, the anxiety, or the apathy are causing greater caregiver burden. I actually didn't think that was going to be the case. I thought actually apathy was going to be a better predictor of caregiver burden, simply because that's at least what I thought I was seeing clinically from an anecdotal standpoint, is that family members would come in and say, my family, or my husband, my wife, they're just sitting on the couch. They're not motivated to do these things that they used to do, which is one of the definitions of apathy. Another definition of apathy is that they're just indifferent. I just don't care. I'm neither happy nor sad. I'm just kind of here. I'm just indifferent. And we actually have shown in some papers that we're working on that the indifference and the amotivation are two components of apathy that seem to be separate and have different predictors of their relationship with other symptoms. And then the other thing that we looked at too was, how does it relate to caregiver depression? So basically, using the same exact scale for depression that we use in Parkinson's, how does that correlate with the depression, anxiety, and apathy in the patient? Well, we're dealing with people probably who are more in the mild to more moderate stages. This pattern of relationship may change in people who are having more severe motor symptoms. We just don't know that quite yet. But I just thought that these data were interesting in showing that the impact of these mood symptoms can be quite different depending upon what you're looking at, whether it be quality of life, caregiver burden, or caregiver depression. I'm not going to touch a great deal, or I'm not going to talk a lot about the more serious, and I don't want to say that one is more serious than the other, but the more psychiatric presentation of things like the visual hallucinations and the delusions. And the delusions tend to be more problematic for family members, as you might anticipate, because the delusions are oftentimes directed towards the caregiver. This person is going to abandon me, they're having an affair with somebody, my grandson who's coming over to my house is stealing my money. Those things, as you can imagine, can be very, very difficult to handle. There are newer medications now that I think Arcadia is the one that has developed a medication for the treatment of hallucinations, visual hallucinations. And it came to the market with that as being the indication. But they're also looking at whether it's going to help with delusions, and they strongly feel that it is going to have some improvement. So another symptom that we have not had much luck at treating is we now have something on the horizon in terms of possibly being able to treat that. So let me just kind of summarize here, that cognitive deficits are highly prevalent in Parkinson's disease. There are emerging approaches to treat and perhaps delay the cognitive decline. Again, that flattening the curve, as I keep saying. Mood issues are also highly prevalent in Parkinson's disease. And these mood issues not only contribute to patients' quality of life, but also caregivers' mood and burden. So it really is kind of getting back to that first slide, is that we have a lot of these bubbles in Parkinson's, and there's many arrows that are connecting these things together. Yeah, that's good in some ways. You fix one and maybe something else will improve, but it can also be bad in other ways. If you fix one, something else might get worse. So I like to describe Parkinson's as a dance. You don't know what song is going to be playing that day. You don't know who's going to be dancing with you that day. And you don't know if you're even going to feel like dancing that day. But once you dance, you feel pretty damn good. Oh, I'll leave it at that. Thanks.
Thank you very much for joining us. We really, really appreciate it. Travel safely.
Thank you, guys.